So thank you for your attention so far today. And the purpose of the first session was really just to pull back, because when you dive into a controversial subject, very quickly you can have a million opinions, and you can have a lot of misunderstanding where people are coming from. So I wanted to just remind us what it is we're doing in Jesus, and that's the center. And so we're not leaving that Christian foundation behind. I'm not going to be speaking as explicitly about it because we're going to be talking about some things directly related to MAiD. But that's in the background. And it should remind us about I wanted to point to this holistic nature of following Jesus, right? It involves God's commands, but it also involves becoming people of character. It involves a community. And I think if there's a lot of information there, so I would encourage you, just ask yourself, what are my takeaways for today? What are one or two things God said to me during that time? This whole thing's a journey. We can't do it all at once. So that's part of this, is that even engaging an issue like MAiD, there's no quick fix to this. So you're not going to get the answer today. We're going to step back and be able to reflect on it and maybe ask some questions about what are some really important things that we need to make sure we pay attention to. And there are tensions in these things. There's no quick resolution. That's why I think finally addressing an issue like MAiD is actually going to take communities doing life together in significant ways. That's where we're going to end the lecture, coming back to what the church can do maybe holistically. But I want to get into this topic because that's what we're here for, specifically to think about Christian discipleship, yes, but what does this mean in the context in Canada today where medical assistance in dying is the law of the land, and it's got increasing implications and maybe decreasing controls around what it is. I want to start by acknowledging that this is a very personal topic, and Andrew had already said that earlier. It's personal for many of you, if not all of you, I'm sure, because people die, right? All of us die eventually, and many of us have had to face death in different ways, whether it's a loved one or whether it's walking through some kind of health crisis yourself. This has come up in my own life in a bunch of different ways, partially by seeing relatives die, particularly grandparents, both my own and my wife's. And some of these issues come up where you deal with inadequacies in the healthcare system, pain medication not being delivered properly, supports not being there, information not being there, controversy within families, because ostensibly you're after the same thing, but you can't agree on the means to get there. All of these things are very much part of end-of-life conversations, and they're things that physicians run into all the time. How do we get people to focus on their common values and then to work through the means? So these are tough things. And in addition to family members, Andrew alluded to, and some of you may know because I've heard that some have been prayed for me, I underwent a fairly severe health crisis a few years back. In 2019, I suffered a cardiac arrest. It was the Widowmaker, the one that just comes fairly instantly. It was 100% blockage to the LAD, the major artery, and very few people survive or recover from that. I underwent chest compressions for like 20 minutes, defibrillators, and that was only the beginning of the problems. I was able to be revived and had surgery and so forth, but then a whole bunch of things spun out of control. You can hear more about that maybe another time. And make a long story short, I was in a coma for a month. I ended up with a severe respiratory condition that was equally life-threatening and actually lasted longer than the heart problem initially did. Multiple organ failure. I didn't know if I would ever have kidney function again. And there were times during that time where I suffered. I'm not going to say my suffering is the worst suffering. I believe lots of people have suffered far worse than I have. I think my family actually suffered far worse than I did personally. But there were some things. I was on crazy amounts of drugs. I had delusional memories, some pretty horrific ones. some procedures that weren't that enjoyable. I really disliked undergoing dialysis. And contemplating having to do dialysis several times a week, 3-4 hour stints for the rest of my life, was a very difficult thing. So I remember at one point lying in a bed when I couldn't move myself very much and undergoing these procedures that were very difficult because of the vulnerable state I was in. They were, I think, more difficult. I remember, thinking I can understand why someone might want to end their life. Seeing the toll it takes on my family, thinking about like my wife caring for me like this for who knows how long, the burden I would become. I understood it. I understood that decision. So I'm not coming to this flippantly or dogmatically. On the other hand, I also, with some distance, understand how very vulnerable I was at that time. And I think probably incapable of making a decision of that magnitude, precisely because you feel the weight of all of those things very, very closely. So that's just a bit of a personal introduction. This is personal for all of us. It's not easy. It's also a question that the church hasn't faced in this way before. Now, the church has had a fairly consistent position throughout history against taking life, against euthanasia, against various forms of taking life. Sometimes it accommodates. We could almost say, like when Jesus says, because of your hard hearts, God might accommodate some things. The question of war is a good example. Should Christians go to war? It's never a good thing. Is it sometimes necessary? Right? It's a tough question. Similarly, this raises some tough questions. Today, I just want to kind of paint an overall picture, a big picture in terms of what is MAiD, what's going on with it, what are some pieces that we need to attend to. This is not going to give you the answers. It maybe initiates an ongoing conversation for you, for your church, and for our culture, because our culture's not done discussing this either. It's a big one. Let me begin by citing some principles of biomedical ethics, because again, this is not just a Christian issue, this is a society issue. There's a book called Principles of Biomedical Ethics by Beauchamp and Childress. It's a very widely used textbook in medical ethics. This is like the 8th edition, I think. It's used a fair bit. And it talks about key principles that inform the practice of medicine, 4 of them to be exact. Now remember that diagram that I gave you. Basically, medical ethics focuses on this principled level of ethical thinking. And just to remind you, there are strengths and weaknesses to that decision alone. The strength is you can talk about issues in a wide societal context, right? Because principles are a little bit abstract, like love your neighbor. That's not hard to say or affirm. What does loving neighbor entail? That's much more difficult, right? So at the level of principles, we can talk about what's important in medical ethics, and then we can create rules that enforce those principles and protect the values we have. But underlying those principles, we have to ask, well, why do these principles even exist? Like, what's their foundation? Now, doctors don't always ask that question. They're not philosophers. When I've done ethics training with physicians, and when I was in Manitoba, I remember being sort of shocked to realize they don't actually get a lot of ethical training. It's kind of like a handful of seminars or something. So the question of like what we should do sometimes is easier to answer maybe than like why do we think that's the case, because we don't think about that. But as Christians, I think we can think about that, and we should and ought to think about the underlying values. So I just want to very quickly alert you to these. The first principle that they discuss is called the principle of autonomy. And autonomy is basically a principle that attends to protecting liberty, freedom, and protecting agency, someone's ability to make choices. Okay? I think autonomy, properly understood, is not simply the right to have everything you want. Okay? Sometimes we think of it that way. That's not really the spirit of what autonomy was, how it developed. It's not the right to have anything you want, but it's more like a negative right in a way. It's like the right not to be violated or coerced or manipulated or misled or left in the dark or any of those kinds of things. Okay? So one good application, or one good example of an application of the principle of autonomy are practices that govern informed consent in medicine. So if you're going to undergo a medical procedure, even if you're going to be a research participant in a study at a university, you have to be given the opportunity to consent. And consent has to be thorough, and it actually has to be ongoing. In a research study, it's not, you don't consent once. You remain open to consent throughout the entire process, and you can decline at any time and withdraw yourself. So consent's important, and one of the things that matters with consent is you have to be of a right mind to give it, right? Or else you don't actually have autonomy. So if I'm not in a place where I can make decisions of myself because I'm in a coma, I don't actually have personal autonomy, and so I have a decision maker on my behalf, which is my wife, who can make that decision in my best interest. But autonomy is the principle. Informed consent is the rule that kind of guarantees that principle is being followed, or at least tries to. From a Christian perspective, why might we want to promote the idea of autonomy? Well, I would say that autonomy has roots in the notion that every individual matters. Autonomy protects the individual. It protects their agency, their liberty, and every individual matters. Why does every individual matter? Because every individual is made in the image of God. So we can't treat people simply as a group or a class. We have to recognize their individual uniqueness and value and dignity. And those things are things traditionally that we have based on the notion of the image of God. We're made in God's image, therefore we have this dignity. This is grounded ultimately not just in something about us, though. It's actually grounded in God's rights to human beings, theologically speaking. So it's one thing to say that I have my own dignity and autonomy, but actually deeper than that is the fact that I'm actually not my own. I have a creator, and I belong to this creator, and this creator has rights over individual persons. So if I'm violating your bodily rights, if I'm attacking you, I'm not just hurting you, I'm actually offending God, because you belong to God, right? So that's really important. So God has rights to his beloved creatures. We belong to God, as one of the catechisms say, in body and soul, in life and in death. And that is the source of our hope. The second principle is called non-maleficence. Ooh, that's a big word. Think of the character, the Disney character, right? Like Maleficent, evil queen, right? Well, non-maleficence is the opposite of that. We're doing no harm, right? So first, do no harm. This is a key principle in medicine, going all the way back to the Hippocratic Oath. First, do no harm. And it really undergirds the idea that physicians are there to serve health and flourishing and functioning, not to do harm to their patients. From a Christian or biblical point of view, I think this aligns with lots of places, but we could go to the Ten Commandments, for example. Do not kill. Do not kill. That would be a foundational kind of command that would apply in this context. And Jesus expands the intensity of this command because he says it's not just that you shouldn't kill. You shouldn't do anything that is a kind of assassination of your neighbor, a character assassination or speaking angrily to them, right? He says anybody who speaks in an angry manner is guilty of violating this rule, he says, because that's the spirit of it, not just the letter of it. So do not kill. We want to avoid doing unnecessary harm. Now, sometimes in medicine and in life, we end up doing harm that's not intended because it's not our primary goal, but can be a kind of side effect of the good that we intend to do, right? So some medical procedures are painful. The pain is not the intended goal, but unfortunately it's an accompanying side aspect of that procedure, right? So like getting a colonoscopy, for example, right? You might undergo some discomfort and pain. They're not trying to put you into pain. That's not the goal, but it accompanies it. It's like in war. Sometimes innocent people are harmed. That's not the goal. In fact, you're really not supposed to do that in just war theory. You have to distinguish between guilt and innocence. But sometimes there is a cost in terms of people getting harmed. So there are choices that need to be made. You think of cojoined twins, for example, where you can either not save either of them, or you make a choice to save one if they're conjoined in certain ways. So we have to discern good from evil. We aim to reduce suffering while avoiding the doing of evil. That notion in medicine is referred to as double effect, right? That sometimes by pursuing a positive intervention, there are unfortunate side effects or things that have to happen. Like removing a diseased leg, let's say. There are some really negative consequences involved in that. But that's not the goal. That's the unfortunate, necessary evil that goes toward the greater good, you might say. Beneficence is the positive dimension. That medicine is about providing benefits, and there's always the weighing of benefits versus harm. So we provide benefits, but sometimes we have to ask, at some point, benefits can sometimes provide a diminishing return. So this comes up with end-of-life things with respect to things like extraordinary measures. The question of, is it acceptable to pull the plug? Is that the same as MAiD? Well, traditionally, we've understood those to be different things, because the goal in withdrawing an extraordinary measure is not to kill. It's simply to stop prolonging the dying process, right? And actually what it does, it allows the underlying disease to do the killing. It's not a personal direct agent that does the killing. So both conceptually and legally, there is a distinction between those things traditionally. So sometimes in providing benefits, you have to balance harms. Sometimes you have to think, okay, is this thing that was once a benefit continuing to be a benefit, or is it now doing more harm than good? Because that can happen over the course of a treatment sometimes. We promote the welfare of patients. So this is the positive. It's not enough to simply say, do not harm. Just like Jesus, it's not enough to say, don't kill. The positive love command is much more expansive than that. So it's not just don't do harm, it's actually we are here to serve the welfare of patients. It's sort of like the biblical notion of shalom. Peace is not just the absence of violence. It's a positive presence, right? It's God's peace and goodness filling something. In the same way, medicine seeks to provide a place of flourishing, not simply the absence of harm. I think this fits very nicely with the notion of loving God and loving neighbor, especially that agape notion that God initiates love, that his love is an overflow, right? It's not just doing the bare minimum, but it actually seeks to do the ultimate good. And it serves the primary goals and purposes of medicine, which is to promote health and to prevent disease. Now sometimes, and I kind of alluded to this can conflict with the principle of autonomy. I guess I didn't talk about this one. So sometimes we end up having to do good in a way that might violate somebody's freedom, but we feel that that's justified. Parents do this all the time. We recognize that our children are free and they're agents, and we don't want to crush their agency. But we have a paternalistic duty, literally, to help them make choices that are good for them, even though they may not know it. Now, sometimes this happens in medicine. Now, generally speaking, we reject strong forms of paternalism because the principle of autonomy would prevent that. But think of, for example, suicide intervention, where there's sufficient evidence, and it's not a high standard, it's not like unreasonable doubt, but there's sufficient evidence that somebody is a danger to themselves. Then actually this notion of beneficence comes in to say this person can be brought to the hospital, right? There can be an intervention. That might override their autonomy temporarily because they're not in a state to actually be autonomous in some ways. But notice the tension there, right? How much paternalism is too much paternalism, right? And how much autonomy is too much autonomy. It's tough. And then finally, justice. Justice is the principle that concerns things like fairness, desert, entitlement, rights for all, not just me, the individual, but how do my rights relate to your rights? And are there any duties that correspond with my own rights? Like, do I have a duty to respect your rights? And then there's a real interplay at work, right? Like, like if it's a situation where everybody's like, well, it's all about my rights, well, then nobody gets what's their rights because everybody's only looking out for themselves. But what duties might be implied? How do we think about justice? So in medicine, this would include things like, how do we try to ensure that everybody has, relatively equal access to medical care, equitable distribution of medical treatments, and so forth. This is a very relevant issue in MAiD because there's a huge issue of distributive justice in Canada that's problematic. I'll come back to that later. This aligns with biblical notions of stewardship, that we are charged to use our resources, all of our resources, because they belong to God, not to us, in order to serve God and bless his world. So it aligns with stewardship. It also aligns with the prophetic call for justice that we see in the prophets. And maybe especially the call to honor the marginalized, the weak, the vulnerable. If everybody's insisting on their own rights, then we very quickly enter into a situation where those unable to assert their own rights get trampled upon. Right? And so justice says, well, what about the weak, the marginalized? What about those who don't have power? And then problems arise with justice because it's really hard to get equitable distribution when you have limited resources, and then you end up competing for those resources. Now, I want to make one important observation here that I think the church needs to be alert to and just realistic about. In our present society, the principle of autonomy has risen to be the dominant principle in how we think about medicine as a society. That's a descriptive comment. I don't mean to say that's a good thing. But just descriptively, I think partly because of the loss of a religious framework and the loss of notions of sanctity of life and so forth, and the emphasis on things like consumerism and individualism and all of that, personal autonomy has really risen to the above. So my right to make the choices that I want to make that give me control, and I don't mean all that to be negative. Some of that actually is really important. But when you select one of these principles and bring it into a place of isolation, the balance gets lost. And the principle ceases to be what it actually is. So remember I said autonomy is not simply getting what you want. It's actually about not being coerced, not being manipulated, not being subjected to treatments you don't want. But what it begins to turn into in our society is that I have a right to this, right? So what results is a kind of truncated, distorted notion of autonomy, really that can become individualistic entitlement. And that has really important implications for how we think about ethics medically, and maybe how the church thinks about it too. Like, I don't think we should be naive about this in the church, that we are actually called to a life that isn't just about ourselves. So it's a delicate balance. Every individual matters, and in a sense, nobody comes to Jesus like for you. You have to come to Jesus on your own. Jesus makes you an actual individual, but he also brings you into community with others. And so we need to be careful in thinking about this and be aware that in our discussions in public, autonomy is the primary value, the individual and their rights and what they want. That's led to a kind of consumeristic understanding of medicine. It's the patient's demands that increasingly determine how medicine works, rather than some notion of human flourishing, for example. Okay. So that's just an initial introduction to some of these ideas. I want to now talk a little bit about suffering. Because I think most of us think of MAiD, or some of the terms that came before, like physician-assisted dying, as really being about the alleviation of suffering. And why wouldn't we want to alleviate suffering, right? Like this, and this is what I really identified with. Lying in that bed thinking, if this is how things are going to be, I don't know about this, and I don't know about this for my family, right? Suffering is difficult. So I just want to reflect a little bit about suffering and what suffering is. And this will play into how we think about these issues. So we need to distinguish, first of all, suffering from pain. Pain is something that's a physical issue. And generally speaking, pain can be managed effectively. I'll come back to this point, not in all cases, but in most cases. Suffering, on the other hand, is much more complex than simply pain. Suffering involves us at a much bigger level. It's an existential kind of thing. So suffering is complex, it's comprehensive, it involves us as persons. Part of suffering isn't just experiencing pain, it's about thinking about the fact that we're experiencing pain and thinking about the implications of that and the social, it becomes instantly more complicated, right? So Megan Best, who is a specialist in palliative care and a world-renowned researcher in this area, says this. She says, this is what suffering is, an all-encompassing, dynamic, individual experience of alienation, helplessness, hopelessness, and meaninglessness in the sufferer, which is difficult for them to articulate. It is multidimensional and usually incorporates an undesirable, negative quality. Another quotation I have from another researcher, his name is Edmund Pellegrino. This is from the Journal of Clinical Ethics. And again, he's reflecting here on suffering and the complexities involved. He says, seriously ill persons suffer commonly from alienation, guilt, and feelings of unworthiness. They often perceive themselves and are perceived by others as economic, social, and emotional burdens. They are exquisitely susceptible to even the most subtle suggestion by the physician, nurse, or family member that reinforces their guilt, shame, or sense of unworthiness. Much of the suffering of dying patients comes from being subtly treated as non-persons. If the emotional impediments are removed and pain is properly relieved, there is evidence that many would not choose euthanasia. So this raises an interesting question as we think about what suffering is, and then we relate it to physician-assisted dying or medical assistance. We can ask, why do people ask for MAiD or physician-assisted dying? And there have been a number of studies on this, both before and after its legal implementation. Megan Best, again, whom I quoted earlier, says that often it has to do with some of the things just talked about: alienation, a sense of meaninglessness, loss of autonomy, but also a sense of being a burden on others and so forth. Also a sense of the anticipation of what might happen down the road can be very scary. And she writes that actually those who enter palliative care tend to choose the option of euthanasia far less frequently if they're being provided with proper holistic care. She says it's only about, now this was a few years ago, I think it's probably gone up since MAID's been offered, but about 1% of those who begin palliative end up deciding to choose euthanasia or MAiD. A study from Hendry and so forth sought to think about why do people want the right to die. This was published in Palliative Medicine, and it looked at 94 survey interviews, and it tended to point to poor quality of life and the desire for a good quality of death. But specifically, things that were mentioned in terms of why people asked for MAiD, things like experiencing loss of function, leading to feelings of helplessness, loss of dignity, loss of meaning, loss of humanity or sense of self. Dependency on other people and feeling oneself to be a burden was said to be intolerable. Physical pain, or, and this is interesting, more often, the fear of physical pain and other physical symptoms. The right to choose and desire for autonomy with regard to the manner of death, this notion that I want some control over the manner in which I'm going to die. And then also financial pressures on patients themselves as well as on their families. And this is perhaps magnified in the US, but it's present in Canada too. So that's a big issue. And then Wilson et al., in a piece in Health Psychology entitled Desire for Euthanasia or Physician-Assisted Suicide in Palliative Cancer Care. This was a Canadian study, and it outlined some of the reasons patients gave for contemplating physician-assisted dying. And I've highlighted some of the higher figures. It's just interesting to look at. One of them is a psychological factor of a sense of being a burden on others. And then there are several physical symptoms that get cited as well, from general malaise to pain, to drowsiness, weakness, to nausea, and some other things. Now, I think that's interesting in part because these are things that can actually be alleviated. And so if they become driving factors for choosing MAiD, that's a little bit unfortunate. Now, I didn't say eliminated. There's a percentage that can't be eliminated when it comes to pain, and that's very difficult. But to have people potentially suffering when they don't need to be is to lead them into a false dichotomy of choice of, suffer unnecessarily or receive MAiD as an exit, right? So coming back to the notion of suffering again, suffering is not a medical condition, properly speaking. Now, medicine attends to some dynamics of suffering. Suffering is an existential condition. It's physical, it's psychological, it's social, it's spiritual. And medicine itself is simply not equipped to treat suffering. That's not its purpose. In this holistic sense, it can tap into certain dimensions and help, but it can't actually solve the problem of suffering because it's a multidimensional problem. And this is why increasingly we have health approaches that are multidimensional, multidisciplinary, more holistic, more integrated, although you have to kind of be lucky to live in a place that gives you access to centers like that in Canada. Okay, dignity. Dignity is a very important word in this discussion because we often talk about dying with dignity, right? Actually, that's the law that was passed in Oregon to allow for physician-assisted dying. It was kind of the Dying with Dignity Act, right? So the notion that physician-assisted dying or MAiD is rooted in the desire to preserve dignity. So dignity is a key idea. And dignity is really fundamental to Western notions of personhood. Now, it might be important in other traditions as well, but in the West, it's grounded ultimately in this sort of biblical Judeo-Christian notion that every human being is made in the image of God, therefore has dignity, and therefore on top of that we build rights that try to safeguard that dignity. But dignity is not a self-evident idea. It's amazing that we all agree on it. I mean, it's amazing. It's really cool. So here's the UN's declaration. So the United Nations Declaration on Human Rights lists a whole bunch of human rights, but at the very beginning, in its preamble, it says, this is what all these rights are based on. It says, whereas recognition of the inherent dignity and of the equal and inalienable rights of all members of the human family is the foundation of freedom, justice, and peace in the world. And then it goes on to say, therefore, here are all these rights that we affirm. And it's a beautiful statement, but the interesting question is, what is dignity? And how do we know we have it? Like, it's not a scientific idea. Like, you can't do surgery on a poor person and open them up and be like, oh, there's the dignity organ right there, right? Or put somebody under a microscope and, or maybe look at their DNA. Oh, there's the gene for dignity right there, the genetic sequence. So what is it exactly? It's not a physical thing. So it's not a scientific thing. There's no test for it. How do we know we have it? What is it exactly? And it's also not a common idea throughout human history. It's a relatively recent idea in most circles, or the idea that all human beings are part of one human family bearing this kind of dignity. The Oxford historian Felipe Fernandez Armesto says this. He says, for most people in most societies, for most of the past, the limits of humankind were narrow. So you might recognize the dignity of your own group or tribe, but that group over there, well, no, because they're not quite human the way we are, right? So these things are kind of wrapped together. What's your notion of humanity, and what is dignity? Why do we have it? The ethicist David Gushee, who did his doctoral work in Holocaust studies, so very interested in things like dignity, said, indifference toward most members of our fellow species, with special hatred for a few and special reverence for a different few, seems the common human experience. So this notion isn't self-evident, and the reason I say that is that it's actually something we have to stand upon and protect and proclaim, because it's not a thing. It's an idea. Right? Dignity's not a thing, it's an idea. Where does this idea come from? Philosophically, like, it's a philosophical idea ultimately, right? It's not an empirical thing. So we can ask questions like what is dignity? One of the pages that I've given you, by the way, that I'm not going to go through, it's just something for you to ponder, and maybe you could use in small groups or something, is a list of questions, because we often make assumptions when we use words. So I've just listed a whole bunch of things that we need to think through in these discussions. One of them is, what is dignity? Or what is a life worth living? Like, how do we define that? And who are we leaving out in our definition when we do? What does it mean to show compassion? And is there or can there be meaning in suffering? Can there be hope? These are not obvious questions to answer from just an empirical kind of perspective. Is dignity basically social utility? I remember a family member once who was dying, and it was really hard because at the end of his life, even the kind of family around him was sort of like, it's really unfortunate that he's in this situation. Like, it'd be better if he just died. Why? Well, because all his life, he was like a type A, highly successful, lots of abilities, always in command, always the center of attention. So who is he when that stuff begins to go? Well, he's nobody. If your definition of dignity is social utility. And it seems to me that we do tend to drift into this in our society, that I have value because I'm of use, right, to society or economically or whatever, to my job. So that if my identity is in those things, then I'm not able to do those things anymore. I begin to lose my identity and my sense of dignity. Closely related is sometimes people will base the notion of dignity in capacity. My ability to reason, my ability to exercise autonomy, and so forth. But again, the problem is when you define dignity in that way, you automatically leave out certain categories of human beings, right? Like those with mental disabilities, or perhaps those like me who was in a coma. So when I'm in a coma for 30 days, I don't have autonomy, I don't have rationality. Do I have dignity? I think you'd want to say yes, but why do you think that? Like, what guarantees that exactly? Is it a social contract? Do we agree that we have dignity simply as a matter of, I need you to respect my dignity. So if you're going to respect my dignity, then I'm going to have to respect yours. So we're going to enter into a contract with each other, right? So that if you respect me, I'll respect you, and we've done a little deal there. And that's kind of how we do it in the Western world. We enter into social contracts to do that. The difficulty with a social contract is you don't have a lot of motivation to make a contract with somebody else when you don't need anything from them. So we'll honor it when our own needs are at stake, or maybe when our own safety is at risk. You can even think of this in terms of nations. Like, yeah, we want to be in a social contract with the United States, but who cares about some tiny little country in Africa somewhere? I'm speaking kind of, I don't mean that. But they're not going to pay back, and we're not threatened by them, so we don't need the contract, right? So there's a self-regarding starting point for the social contract. So what happens when you're not in need, right? We might ask too, if we have a social contract, why do we even need the word dignity anymore? We simply create rules to protect ourselves. Well, because I think very quickly it becomes apparent that we might ask, well, why do these rules exist, like they seem arbitrary. So we actually need this notion of dignity on which to put the rules. But again, what does dignity rest on? What is it exactly? Why do we believe it? Is there ultimately a religious basis for dignity? And I think the answer is yes. It's not that you can't believe in it if you're not religious. Lots of people do, right? It's just that if you can be someone who takes the Judeo-Christian tradition, right, and what it has to offer, you can actually say, you can get down to that level to say, actually, dignity is preserved because God, who supersedes all of us, ensures that it does. He declares it, and he asks us to honor it. So it's an authority beyond ourselves. Okay? You can almost say we have dignity because God says it in the same way, I mean, not completely the same, this is an analogy, it breaks down, but in the same way that an $1,000 bill has the value it does. It's not the paper that has value. It's the fact that it's got a stamp on it that refers to what's been kind of invested in it or declared over it. And in that sense, God has declared all human beings to bear his image and to be of value and dignity. So I think we really need to wrestle through, because how you define dignity has big implications for how you think about what is a life worth living, or who matters, or who's vulnerable and needs extra precaution or care. Where might justice need to kick in some important ways to balance out that individual desire for autonomy that we all want to assert. If you want a book that really traces through the notion of dignity and kind of where it's come from historically, I'll just recommend this book by David Gushee. It's a very thorough, excellent book on this topic. It's called The Sacredness of Human Life. He said he wrestled with this title because he thought people would just think it's about abortion. It's not just about abortion. He does talk about it in a chapter somewhere, but it's about dignity much more broadly conceived. Humane care for the dying. Humane care for the dying. How do we care for the dying in a humane way? One of the ways that we have sought to do this in the modern world, and actually the movement has Christian roots, is through palliative care and hospice care. Palliative and hospice care are effective ways of walking with the dying, helping them to live as best they can with the time they have, with as little suffering or pain as possible. It's effective, it's holistic, it's patient-centered, and it truly seeks to be humane in its treatment of human beings. The World Health Organization provides the following points to define palliative and care and hospice. Now, to make a cleaner distinction, often there's a distinction made between hospice care, which really is end-of-life kind of acute care when somebody's entered the final stages of dying, and palliative care, which you can receive at any point when you need extra medical help to deal with things like pain and extra services and so forth, assuming you have access to it, which is a big assumption, actually. So palliative and hospice, the aims are to improve the quality of life of the patient and their families facing life-threatening illness, to affirm life, to regard dying as a normal process. So in a sense, dying is not a medical condition itself. It's a normal thing that we all face. But how do we help people in the midst of that process? This is an important point here. It aims neither to hasten death nor to postpone it unnecessarily. So it's not about extending life by all means necessary. It's patient-centered in the sense that the patient might have goals. The patient might actually say, I want to live as long as I can because I want as much time as possible with my family and loved ones. Palliative and hospice would say, okay, let's help you do that and equip you to be able to do that. A patient might say, you know what, I'm done. I don't want extra measures. Can you just make my passing as humane and pain-free as possible? And the response would be, yes, we'll do that. So aims neither to hasten nor postpone death, provides symptom and pain relief, offers a support system for active living, offers support to help families cope, and integrates physical, psychological, social, and spiritual aspects of patient care. Here's a quotation from a physician friend of mine in Manitoba who is a palliative care oncologist, so he deals with cancer patients. Some of his cases are really, really hard, difficult, horrific cases. But he's a strong believer in palliative care. He writes this, he says, palliative care is about living well with whatever time you have left. People are sometimes afraid of palliative care because they equate it with giving up or dying, but we are all about living. It is patient and family-centered, following what the patient's wishes are at the end of life to help them live well. Our focus is not to extend or shorten life, but if the patient's goal is to extend life, we will still stay active and involved to help with keeping pain and symptoms under control. We sometimes use sedation in the final days of life if symptoms cannot be controlled in any other way. This does not shorten life, but helps the patient attain comfort by sleeping. MAiD is not part of our practice. And he's expressing a position that would be a predominant position in the palliative care community. Not universal, but pretty predominant in the palliative care community. Megan Best, who again is that world expert who does a lot of research in palliative care and works at special treatment centers, says that in approximately 90% of cancer patients, pain can be controlled effectively. Actually, that comes from the U.S. Department of Health statistics. And she says that in specialized centers, they can achieve even better results than that. Now, that's a pretty high percentage. That means most people shouldn't have to suffer intensely or unnecessarily. But it's still 10%, right? Or maybe it's 5% in the really specialized centers. And that's still a lot of people, right? And I think that's something that should be acknowledged. Pain cannot always be fully dealt with, but in the vast majority of cases it can. Here's the problem, though. Palliative care and hospice are severely underfunded and underrepresented in Canada. Here's a quote from the Canadian Cancer Society. Medically necessary services are not defined in the Canadian Health Care Act. It is up to each provincial and territorial government to determine which services are medically necessary. This means services are covered differently by each public health insurance plan. Several provinces have programs or laws that either partly cover or provide financial assistance for care and services related to palliative care and the end of life, but programs vary across the country. In fact, statistics coming from Canada's own government sites say that somewhere between 16 and 30% of Canadians currently have access to what we would actually call good, holistic, integrated palliative care. 30% at a maximum, right? And forget about it if you're in an Indigenous community or if you're in a poor community. And along with that, the very, very best centers, so often the Victoria Hospice Center is mentioned as a high echelon center of care. A lot of them are either significantly funded privately, like 50%, or they were also started by someone who had a vision for it privately. They're not government initiated. So we have a really interesting situation where we have the potential to deal with pain and suffering in a holistic way, but we are severely underfunding it to the tune of 70% or more. And instead we're offering people the opportunity to die, right, as a way out of suffering. So that's an issue. This is a fascinating quotation from this policy brief on hospice and palliative care. The current disparities mean that Canada's health system does not achieve the ethical concept of distributive justice. So this is a major problem too, especially when you consider demographics of an aging population. Like, put these things together. You have an increasingly taxed healthcare system, right? I mean, we saw that in COVID. It wasn't just COVID, though. Like, when I was in the hospital, we've talked about this a lot of times, there was a lot of pressure to move me out of ICU too early because it was like at capacity the whole time. This was before COVID happened, right? There was no space in ICU. So these pictures you see of people in hospital beds out in the hallways, that's not just COVID. COVID made it worse, right? Because it exacerbated the system. But it's a desperately hurting system. Nurses just running off their feet the entire time. I haven't had my break yet, right? Talking to doctors later who began to share, yeah, it's rough. So we have a severely hurting system. We have an aging population. We have increasing numbers who are going to be dying statistically. So larger and larger groups of people are going to be dying at the same time. And in the midst of this, we're not funding palliative care sufficiently, but we're introducing MAiD. And this really plays into the concern that the right to die ultimately becomes a kind of duty to die, right? Because it's just better for the system, better for your family, better for everybody else concerned for you to just cease to exist than for us to fix all of these other problems, right? So that becomes a real strain psychologically as, again, put those facts together, right? Increasingly taxed healthcare system, increasingly aging population, increasing numbers of people dying year by year, and the introduction of MAiD into the midst of that without attending to maybe due process of other choices that might want to be considered first before something ultimate like death is considered. Okay, very quickly, I just want to, because it's helpful to go through this a little bit. This is not going to be in depth, but I want to just very quickly mention some points and counterpoints in terms of why people would argue in favor of MAiD and then why people might argue against it. And again, these are listed in the handout, so you can come back to them and do a future session and talk about them more, maybe, I don't know. But so one argument would be simply, it's my life to end. I want to have the control. I want to have the ability to die the way that I would prefer to die. I think a counterpoint to that, and again, I'm not necessarily saying one just completely wipes the other away. These are tensions. The counterpoint would be that we are not actually just individuals, but we are relational beings. We actually exist in families and in communities. And our decisions have repercussions for others. Some decisions that benefit me might actually put others at risk. So that's a tough one to think about. So our lives, from a Christian perspective, to add on to that, actually don't belong to us. It's like the Heidelberg Catechism says, I belong in life and in death, in body and soul, to God. That's one of the things I really came away from, actually. When I started to recover, I just had this, just a strong conviction that I actually don't belong to myself. Now, it had nothing to do with the MAiD thing. It actually had to do with what am I doing with my life? And not about some great mission or ambition. It's actually, am I present to my family? Am I present to my kids? Am I doing what God places before me? My life isn't my own. I've been bought with a price, secured, right, with the blood of Christ. And not only that, but I'm here on temporary assignment. And that became so clear. Right? Our life isn't our own. We don't have much time. And that factors into this as well. Sorry. Just suddenly struck me. Secondly, I want to avoid anticipated suffering. Of course, right? Of course. Facing suffering is scary and it's horrendous. Again, we need to remember that suffering is complex and that much of what suffering is can actually be alleviated, both with medicine but also with proper care and community and support of others. The counterpoint also is that our perceptions of suffering change over time. This has a lot of implications for this. And it even impacts how we make laws. So when we're, let's say, making laws or we're having courts strike down former laws and so forth, the people making the decisions about the laws tend not to be the people, by and large, actually walking through suffering or facing it or coming through it to the other side of it. So for example, if I were to do a survey of, like 20-year-olds, let's say, and ask them, if you were in a car accident and the guaranteed outcome is that you were going to be a quadriplegic, would you want to live? Most will say no, right? Interestingly, though, if somebody becomes a quadriplegic as a result of a tragic accident, and they pass through a grieving period, probably about 2 years, could be more, could be less, the majority want to continue living and find meaning in life. But perspective changes things. The same thing actually happens if you survey people about becoming blind. You get a similar kind of response. Outside of that is the observation that our perceptions of suffering have much to do with our experience of time and also our experience of purpose. So as one common example, undergoing childbirth for women is one of the most painful things that you could experience. I don't speak from experience. But because it's purpose-oriented and there's an end in sight and it leads to something so positive, it's actually bearable suffering. Not that we don't seek to alleviate it, right? Because we should if we can. But purposeless, meaningless suffering is very, very difficult to bear. It's inhumane, right? It becomes undignified. But if purpose can be found, suffering can be borne. Our experience of time. Most of us, if we went in to get a vaccine, we would experience a few minutes of discomfort. And for some people, more. Little story, our youngest son once got a vaccine at school and I think spent, half an hour chasing him around the school trying to find him because he was so afraid. And not to diminish it, it was a really hard experience for him. Some people struggle. Point being, you can go through something that has a small discomfort and a big payoff, and that changes the nature of your reacting to it. Most of us wouldn't call that suffering. Now, if you were to extend in time that experience, like if you had the experience of a needle going into your skin and extending that for 2 weeks straight, like that intense, that would be suffering, right? The passing of a loved one is deeply, deeply difficult. But as time passes, people begin to live with it, and a broader sense of that suffering begins to change. It doesn't go away, but you do gain perspective. So this is simply to say that often we're pressed to think only of the present moment, and we forget about these larger considerations. Another point, I don't want to be a burden on others. Yeah, this is a big one, and man, you don't want to be a burden on others. I felt that. The question, though, on the other side would be, well, as soon as we feel that, are we in danger of the right to die, having become a kind of burden to die or a duty to die? And if people already feel like they're vulnerable to feel that way, we have to be extra, extra careful to not make suggestions that would just reinforce that. Actually, in the New Testament, we are not called to have no burdens. We're called to bear one another's burdens. I remember an ethicist at a conference I went to once who was with the Anglican Church. His name was Eric Beresford, I think. He's in my notes somewhere. But he actually said, you know what, I want to be a burden on my family because that's what being a family is. A little bit cheeky, but it's an interesting point that we resist that. And as the church, aren't we called to bear each other's burdens? Do we become a community incapable of burden bearing? So it's that question. It's not just is MAiD right or wrong. It's what kind of people do we become when we practice it? What virtues are lost? What practices around carrying and so forth are lost if we go that route? The other comment would be that actually being a burden is part of life. All of us are extreme burdens when we're born for several years. And all of us will become burdens when we die, no matter what our circumstances are. I want to maintain control over the circumstances of my death. I think we should acknowledge loss of autonomy is difficult. And it can feel humiliating. And so in light of that, we need a more holistic understanding of what dignity is. And we can practice dignity therapy. I'm actually quoting a book here that you might be interested in taking a look at. This is from a famous physician who works in Manitoba. I got to meet him once. He's world-renowned for doing experimental research with clinical surveys and everything on what he calls dignity therapy, and how dignity therapy has a huge impact on augmenting a patient's sense of dignity and meaning and worth and value and so forth. And it makes the bearing of suffering much more bearable. Really interesting man. What might dignity ministry look like? Like if you were to read this book and then to say, like, is there any of this that's transferable to a church setting where we can do dignity ministry with each other, remind each other of this, serve this idea? This is another study I'm just going to refer to, but it has some statistics right in there in the abstract that point to some of the really positive benefits of this dignity therapy. Part of the point here is that this is a really interesting, creative, and effective solution that gets bypassed way too quickly if we don't stop to actually do it before considering more extreme measures. I don't want to be a burden on my family financially. That's an important concern. Even in Canada, that's an important concern. And I would say we need equitable access to hospice and palliative care if we're going to deal with that. I want to avoid unbearable pain. Well, as we've said, most pain can be managed. Not all, but most. I have a right to MAiD because MAiD is part of healthcare. It's an interesting, subtle transformation of the definition of medicine and the purposes of medicine to notice, right? It's part of healthcare. But remember, Beneficent said medicine seeks to serve life and its flourishing, not death. On the other side, we might undermine the practice of medicine itself. And in the process, and a lot of doctors are worried about this, we begin to undermine doctor rights. By asserting individual autonomous rights, we undermine things like conscientious objection. I read an article in a bioethics journal published by Queen's University a couple of years ago in which two philosophers were arguing very strongly against the idea that doctors should have any kind of right to conscientious objection. Basically, they should find a new job if they've got trouble doing anything that Canada has determined ethical to do, right? Because once you say it's a human right, well then it's a right, not a privilege. And now you have to provide it, and now you need people that have to provide it, right? We can implement legal safeguards so that MAiD does not get out of control. But there are always unintended consequences of any release of anything, whether it's technology or a loosening of a present legal standard that's been in place for a long time. And these can be difficult to reverse or stop. Just think about how MAiD has progressed in Canada in a very short amount of time. So we go all the way back to early years, like 1993, the Rodriguez case that sort of sided against it. We have Oregon passing its Death with Dignity Act in 1997. This has an influence on how the US seeks out the implementation of assisted assistance dying. The US does not practice MAiD anywhere. It's illegal. And here we come to an important distinction between physician-assisted death, which is the doctor prescribing medication that the patient takes at their own home, and medical assistance in dying, which is the doctor administers the lethal dose of medication. Canada exclusively, almost exclusively practices MAiD. The US exclusively practices physician-assisted dying. They don't practice MAiD at all. The reason being that they think that there's an important safeguard in the patient right up into the last minute being able to self-administer rather than getting into a situation where somebody's doing it to you and you can't say no for some reason, for whatever reason. So they see that as an important safeguard. So in any case, 2015 we had the famous Carter case, which was a challenge to the existing law. 2016 we had BC-14, and this is what made MAiD the practice of the land. It legalized medical assistance in dying. And then in the intervening years, we've had a series of court challenges where, for example, the Quebec court knocked down or laid aside one of the key elements of the Bill C-16 legislation, namely that a death be reasonably foreseeable. So the U.S. has tighter language there. In the U.S., you have to be terminal, has to be within a 6-month period of being terminal that you can do assisted dying. Canada used looser language, a reasonable foreseeable death. What does that even mean, right? That's exactly what's happened in the court since then. Well, reasonable can mean this, or it can mean this, or it can mean this, and it's just kind of expanded. So that's what's kind of happened in the intervening times. We've also had challenges now along the lines of mature minors, mental health, which Bill C-7 is going to implement in 2024. And then other challenges as well. But we've had a very quick progression. People often view a slippery slope kind of objection as kind of extreme. Well, here it is. We've also seen this happen in other places in the world, right? Like the Netherlands, where people were being euthanized against their will, elderly, disabled, so forth. It's not just it might happen, it has happened and it is happening. And so that's a concern. I'm not going to go through these slides very much. These are just the requirements set out for Bill C-14. You had to meet all 6 of these requirements. So you had to be an autonomous individual. That means your autonomy was intact. You had to have a grievous medical condition, which is also irremediable. So in some sense, it's not going to get fixed, right? Endurable and intolerable suffering, competent adult, and death is reasonably foreseeable. Well, this is what the Quebec court struck down, requirement number 6. And then different people have proposed different aspects of this being struck down. And here's where we are with Bill C-7, rather. The only 2 remaining safeguards really are the autonomous individual and enduring and intolerable suffering, which is loosely defined because it can now mean somebody suffering from mental health, where mental health or mental illness is actually the sole reason the person is requesting MAiD. So that's going forward in 2024. Okay, so that's a lot to get our heads around. And I've sought, again, not to solve this issue for us, but to try to draw out some really key things in the framework that we need to attend to as Christians. And remember our earlier session, because, again, at the secular level, we're just dealing with principles, but principles can be abstract, and without a deeper narrative and an ultimate ground, they can be somewhat slippery. Okay, so what does the Christian community have to say about all of this, or how might we be instructed? I want to point to a couple of images. One is that we as the church are called to be a cruciform community. It's a fancy word for a community of the cross, right? The Gospel of Mark has a very strong emphasis on this idea that Jesus is a suffering Messiah, and he goes to a cross. And Christian life is about discipleship, and discipleship is the way of Jesus, which is the way of the cross. Right? We might summarize that with Jesus calling, if anyone would come after me and be my disciple, they have to take up their cross every day, deny themselves, and follow me. So this is a community called to a cruciform form of life where we give up our own rights to some extent. Philippians 2, even Jesus didn't consider equality with God something to be held on to, but gave up his rights as God to become human and to do something for us, right? We're called to be a community of the cross that loves each other, bears each other's burdens, sacrifices for each other. One of the things that Christians should expect in life is suffering. Now, I'm not saying that we should be flippant about suffering or that we should not seek to alleviate it. Actually, most of the people I know in the medical community and the scientific community do what they do because they're seeking to relieve human suffering in some form or another, whether it's through technology or through medicine or what have you. That's very admirable. But suffering is part of human experience, and some suffering has to be borne. Another way of saying that is that God chooses not to relieve us of all the suffering we experience. I don't know why. That gets us into the whole, why do good things happen to bad people, theodicy stuff. It's not the topic of this talk, but even someone as prominent as the Apostle Paul, prayed over and over again, Lord, remove this thorn in my flesh. Whatever that was, we don't really know. It could have been a physical affliction, could have been psychological. And God's response was always, my grace will be sufficient for you. I know it's hard. Stay the course. You're on temporary assignment. Your time is limited. Your life's not your own. There's a resurrection coming. Some suffering can be borne if there's meaning there. If we don't think about suffering seriously, we can become a community that ignores suffering or tries to escape it. We become too sanitized. This is not like the Christians of the ancient world. The Christians of the ancient world, that's what that article I left for you guys is all about. It's fascinating. I'm not going to go through it. But it's fascinating because the article talks about how the early church grew incredibly. But it's puzzling because if you review documents of the era, there's not a lot of emphasis on evangelism or mission. It's like, how did they grow without that? And this historian, he cites certain things. One of the major things is they lived a question-posing life. Like they gave of themselves. The pagans would flee the cities when plague would hit. The Christians would go in to care for the sick and dying. Why? Because they didn't fear death. The Romans were discarding baby girls in the garbage dumps. The Christians were going in, rescuing them, adopting them. Why? Well, because God adopted us. Now we're adopting these little ones. We're saving them. And this was really head-scratching. Why would these people do this? Why give of yourselves? Why allow yourself to be torn up and eaten by lions in the Colosseums? Why would you do that? What's up with you people? It's a people of the cross, a people convinced that Jesus' way is our way as well. And again, when we sanitize the church so much that suffering doesn't happen, right? We don't have children attend funerals anymore. We age segregate everybody. We have a youth idolization in our culture where we just don't have to deal with things like aging or dying. Or as one person said, who was commenting on social media, with having pores on your face because it's all photoshopped away. We don't deal with that stuff. We sanitize it all. And that's not the community of the cross, which takes death seriously, looks it in the eye, and walks through it with people. It's funny, this speaks a little bit to our modern values. The typical modern person would love to go in their sleep in the middle of the night without even knowing it, right? If you were to ask a medieval person, and you were to say, how would you like to go that day? They'd be horrified by that idea. Horrified. Because it allows no time to walk through the dying process, to get your affairs in order, to reconcile with loved ones, and to get business done with God that you may have been postponing for some time. It bypasses all of that. Dietrich Bonhoeffer wrote this: the exclusion of the weak and insignificant, the seemingly useless people from everyday Christian life and community may actually mean the exclusion of Christ. For in the poor sister or brother, Christ is knocking at the door. So in the church, where are the dying amongst us? Where are the elderly? Where are those with afflictions? Where are those with disabilities? And are they an inconvenience, or are they a prominent part of the life of the church? Where's the witness to the hope that Christ brings in these situations? We're also a resurrection community. This isn't just about death. The cross is so amazing because it's so counterintuitive that the one who wins is not the lion but the lamb. But the resurrection comes to vindicate the way of the cross, to say that actually, despite all this death and meaninglessness, and despite the lack of hope we see, God has actually transformed the world and is calling us into that. So resurrection is not a belief that leads to escapism in the history of the church. I think it does in some contexts, like, pie in the sky when you die. So I'm not going to engage in the present issues of the day. I'm just going to withdraw, be a sectarian community. Most of Christian history, and especially if you look at the early Christians that I talked about, resurrection was a key belief that causes Christians to be fearless in the face of death and suffering, financial loss, and putting their own lives and finances and everything they own on the line for the sake of others. Why would you do that if this life is all there is? It makes no sense. But if this life isn't all there is, if in fact this life is a pinprick dot on an infinite painting, right? That changes your perspective on things. Okay, very, very quickly, what can the church do? And I'm not going to talk about these in depth. I want to just make some quick suggestions. These would be great points to come back to in small groups or as a church to say, how might we do some of this stuff? So what can the church do? You can't solve the problem of MAiD, but how do you become a witness that begins to think this through and live amongst people who are suffering, right? One, we can address and attend to the non-physical and mysterious realities of human existence. So this is a recommendation made by Margaret Somerville, who was an ethicist who used to be at McGill University. She's now down at Notre Dame. But she said, nobody in the world is able to talk about, the deep things anymore because we're disenchanted, we're secular, we don't believe in this stuff. The church should be the place where we can actually talk about the sacredness of people, the dignity of human life, and so forth, and actually champion that. Secondly, we can think through again how we can begin to normalize and expose people to death and dying and aging. These aren't evils. Now, in one sense they are. Death is the enemy to be destroyed. But in the Old Testament, there's also this sense that it just happens also. So much of it depends on our response to it. So how do we normalize death, dying, and aging? How do we resist the idolization of youth culture? As great as young people are, and with so much energy and passion, but we've lost a lot of value in terms of the wisdom and stability of an intergenerational community. We can preach and teach on relevant basic Christian convictions, that bottom level, because society doesn't have a bottom level anymore. There's no ground for anything, right? So as a church, we really need to be talking about what are those basic things that there's no why below it. They're like the bottom line. Things like the dignity of the person. Maybe things like the sanctity of the human life, right? The fact that we're not just physical stuff, we're spiritual also. And there might be implications for those kinds of things. We can practice dignity ministry. What does that mean? I don't know. We've got to figure that out. We can raise awareness about and support for effective and accessible palliative care and hospice care. Remembering that in Canada, these things are most likely to happen when they're actually privately funded and driven. This is not a push for private health care. It's just to say it's just not happening. And it needs champions if it's going to happen in Canada. Number 5, the ministry of presence. A lot of us avoid death and suffering because we don't know what to do or say. I totally get that. I've been in places like that, and you feel like an idiot. You're going through this. What can I say to you? It's just be there. That's one thing you can do. And be aware of the need. The patient's tired. They need to rest. Don't overdo it. But it's amazing just what presence can do. And we need to be present not just for the dying, but for the suffering community, right? Because if we're going to bear burdens, we can't just say, well, these are this family's burden to bear. We have to bear it as a collection of families, as a new family of God. So how do we care for the burdens both of those who suffer, but those who suffer with those who suffer? Number 6, we can live as a countercultural, holistic community of sacrificial giving. Man, sometimes we don't even think how simple practices like giving my finances. Because we think of it as my token thing that I'm supposed to do, but what if it's a discipline that's meant to reorient how you relate to your stuff in general? Right? So we can begin to take on sacrificial giving as a practice and relate it to an issue like this. We can demonstrate the love of God in the lives of those feeling abandoned and without hope. We can mobilize our churches and communities to care for those in their communities who are suffering and alone. We got to realize that this is not just about dying. This is about being communities of people in general and a holistic vision for that. People are dying alone because they've got no community to be part of these days. Like if you're not part of a church community, and if you're not connected to a really healthy family, who's your community? Who's your family? And will you be alone in difficult times? And then finally, and these last three I actually drew from the EFC website, got some really good information up there. Ensure people with disability, chronic illness, and mental health struggles are welcomed into full belonging in our churches and in our communities. We need to really challenge the narrative of what a life worth living is. Not just as an accommodation, but as gifts to our communities, which mean that our communities cannot be the people of God without these people, because we're then less than the body of Christ because we're missing members. So that's some of the things we can begin to do. And I want to point back to this Acts 2 community because I think that's such a great model for all of us. Thank you for your time and attention this morning. I think I went a little over. Sorry about that.
Well, thank you, Patrick. We really appreciate you coming. And I noticed on your handout you must have left us 15 questions. And so you are correct in that you didn't come with 15 answers, but you came to stimulate the conversation.